All right, good afternoon, everyone. Thank you so much for joining us for this month's Teach Educational Rounds. Here with us today, we have Laurie Zawertailo, Marium Ali, and Tina Kabir, who will be presenting on Periods and Puffs, exploring the role of sex hormones in nicotine addiction. So we're going to begin today with CAMH's land acknowledgement. CAMH is situated on lands that have been occupied by First Nations for millennia. Lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of CAMH appeared in the Colonial Records Office of the British Crown as the council grounds of the Mississaugas of the New Credit, as they were known at the time. Today, Toronto is covered by the Toronto Purchase, Treaty Number 13 of 1805, with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. CAMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis, and share the land and protect it for future generations. So I now invite everyone to introduce themselves in the chat and let us know which traditional territories you are joining us from today. If you are unsure, you can visit this link I will put in the chat to find out. And you are also welcome to let us know something you are doing to learn or improve your commitment to reconciliation. So I will give everyone a few minutes to do that, and while people are sharing, I will share my own personal land acknowledgement. My name is Rachel. I am a second-generation Canadian, currently located on the lands of the Mississaugas of the Credit, which is covered by Toronto Purchase Treaty Number 13. I am committed to reconciliation. I continue to listen and learn about the stories and cultures of various Indigenous communities and ensure that their voices are heard. So everyone can feel free to continue sharing in the chat where you're coming from. And in the meantime, I'm just going to continue with some housekeeping items. So if you are interested in receiving a letter of completion for this Teach Educational Rounds, please make sure you have registered for this webinar and completed the pre-learning assessment. As well, make sure you have signed into this webinar using your full first name and last name so we can track your participation. And finally, make sure to complete the evaluation and post-learning assessment, which will be emailed to you by end of tomorrow, and you will have 1 week to complete that. And please note, a copy of today's presentation slides will be sent along with a recording by tomorrow as well. So here's a little more information on our presenters today. First is Dr. Laurie Zawertailo. Laurie obtained her PhD in pharmacology at the University of Toronto in 2002. Dr. Zawertailo's research interests are in the areas of behavioral and neurobiological aspects of tobacco dependence and treatment, especially in individuals with comorbid depression or alcohol use disorders, subpopulations who have an especially high prevalence of tobacco dependence and tobacco-related morbidity and mortality. We also have Marium Ali, who is a PhD student at University of Toronto. Marium's research interests include addiction, neuroimaging, behavioral pharmacology, and interests between sex hormones and neural correlates of addiction. And finally, we have Tina Kabir. She is also a PhD student at University of Toronto. And Tina's research interests include addiction, smoking cessation treatment, clinical trials, equity, diversity, and inclusion in healthcare. And here's a list of their disclosures. And please know that the content of Teach Educational Rounds are centered on evidence-based guidelines from the following sources. Nonetheless, these materials, as well as the verbal presentation and any discussion, represent only general principles, and they do not remove the need for clinical assessments or treatment plans by healthcare professionals. So feel free to use the chat feature throughout the webinar to post any comments or answer any prompts from the presenters. To do this, you can click on the speech bubble icon in the control panel, and please ensure you select everyone so that all panelists, hosts, and attendees can read and respond to your comments. And I'll just note that all content-related questions will be answered at the end of the presentation, so please keep note of anything that comes up, and you can post them in the chat during our Q&A period for our presenters to answer. And with that, I will let our presenters take it away.
Great, thanks very much, Rachel, and happy International Women's Day, everybody. Yes, an appropriate topic for the day. We're going to be talking about women-specific issues in nicotine and tobacco addiction, and we're going to specifically talk about sex hormones and their role in nicotine and tobacco addiction. There. Okay, great. So the learning objectives. So hopefully by the end of the webinar, you'll be able to recognize the known sex differences among men and women in nicotine and tobacco dependence, understand the role of ovarian hormones and menstrual cycle phase in addiction processes and in treatment outcomes. And then also acknowledge the limitations of the current literature and evidence base, and then learn about ongoing studies that we're doing here that my two PhD students are doing, specifically investigating the effects of ovarian hormones on nicotine dependence. So, I mean, I don't think I need to explain too much about the effects of tobacco smoking to this audience. We know that it is the #1 preventable cause of disease and death in North America, and the risk of actually dying from a cigarette tobacco-related illness has increased over the last 50 years. We know that combusted tobacco produces over 6,000 chemicals. We know that then several of them are known carcinogens. And even though nicotine is the primary addictive component of cigarettes, it doesn't cause these cancers or chronic diseases. So, but women specifically have distinct negative consequences from smoking. We know that they have a greater risk of mortality from heart disease. We know that they have an increased risk of developing female-specific cancers, such as cervical and uterine cancers, and there's growing evidence of the link between smoking and breast cancer as well. And of course, we've long known about the pregnancy-related complications from tobacco use in pregnant women, including low birth weight, sudden infant death syndrome, and birth defects. And then later in life, continued tobacco smoking is related to premature menopause and infertility. So tobacco smoking affects women across the lifespan, but has kind of perhaps differential effects across the lifespan as well. So, you know, recent prevalence of smoking in Canada shows that women continue to have a lower prevalence overall of smoking compared to men. This difference kind of increases in early to middle age and then kind of evens out later in life. So by the time people are 65 years or older, it's about the same. There's a decrease in prevalence of smoking, probably due to people actually dying prematurely from a tobacco-related illness, but there's an evening out of prevalence of smoking between men and women after the age of 65. However, even though we see this kind of overall decreased prevalence of smoking among women compared to men, we don't really know why that is. We also don't know why women seem to be even more adversely affected by smoking compared to men. But there's certain areas that we can look at. So we can look at not just sex-related effects, but gender and social effects. So, you know, women as a gender smoke for different reasons than men, and that may relate to why they have a more difficult time quitting. There's differential biological responses to nicotine, so that's more of a sex-related effect. And we know that there are differential treatment outcomes between men and women when they try to quit smoking. So with respect to gender and social effects, we know that women smoke to cope with kind of internal affective states. So coping with negative mood or negative emotions or stress. They also are more sensitive to external cues, so more sensitive to social cues. And, you know, they smoke for social reasons in large part. Young women smoke to manage their weight, and that can continue on as young female smokers continue to smoke. And, you know, this used to be a big deal. It's less so now that tobacco advertising is largely removed from our society, but there's still infiltration from American markets, et cetera, that, you know, advertising campaigns that link smoking to female kind of empowerment and freedom and women's lib, et cetera. So, you know, they also have different motivations to quit. So for men, you know, they often cite improving their physical health as a reason to quit. Whereas for women, again, it's an external kind of reason. It's not for themselves. They're quitting for their children, is what is primarily reported. So regardless of why, the motivation for quitting, women do find quitting more difficult. So we know that nicotine patches are 40% more effective in men than in women. We know that, you know, among women of the treatment options, medication options that are available, varenicline is the most effective, but it's still less effective in women than it is in men. And we know that among men and women, even with behavioral support and nicotine replacement therapy, women are less likely to quit than men. So within the STOP program, have a large amount of data. We looked at this difference between men and women in 6-month quit outcomes. And you can see that, you know, among women, their quit rate at 6 months was 24% compared to 27.5% in men. And that you may think, well, you know, 3.5% difference in quit isn't that big of a deal, but it's not only statistically significant, but clinically significant as well. You know, that translates into thousands and thousands of women who were unable to quit compared to their male counterparts. And this is after controlling for all the things that you think might be different between men and women. You know, socioeconomic status, employment status, other things, you know, when they started smoking, age of initiation, that sort of thing. And we also know that it was not due to differential use or dispensing of the nicotine replacement therapy. So even after we controlled for perhaps women getting less NRT or a lower dose of NRT, there was still this significant difference between men and women and their quit outcomes. So we still don't know why we have this differential effect. So, but we also know that biologically that nicotine does affect women differently than men. So, you know, when women smoke non-nicotine cigarettes, they subjectively report an equal relief of withdrawal symptoms and craving compared to when they smoke a nicotine cigarette. So it's not really the effect of nicotine that is relieving withdrawal, it's the act of smoking a cigarette. We know that men, compared to women, are more vulnerable to the biological effects of nicotine. So they smoke for the nicotine more than women do. And women, when they do try to quit smoking, report higher nicotine withdrawal symptoms and urges to smoke compared to men. And as I stated before, men smoke for the positive effects, reinforcing effects of smoking, so the actual nicotine effects, whereas women smoke more for negative reinforcing effects. And by that, I mean, relief of withdrawal or negative affect, mood, stress, etc. So with respect to women and ovarian hormones, there are differential effects of the two main ovarian hormones, estrogen and progesterone, which we'll go through. And then there's also effects of combined effects of ovarian hormones. So when they both change drastically during pregnancy, and there are some effects of birth control, hormonal birth control. And then there's also potentially some effects of menopause, which we'll explore a little bit. And then some effects of, we'll go over kind of what's known to date about the effects of hormones and menstrual cycle phase on treatment outcomes. So with respect to estrogen, you can see from this graph here that estrogen is in the kind of green line, and it peaks just before ovulation during what is known as the follicular phase. So the late follicular phase is when estrogen is the highest. And we know that when estrogen is high, there's an increased dopamine release in response to nicotine administration. This is in animal studies as well as human studies. There are some studies that have shown that there's a significant increase in what is known as Curie Activity during this phase, and that means how the brain, specific areas of the brain, respond to either picture or video cues of smoking-related, either pictures or videos of people smoking or smoking-related paraphernalia, etc. And we also know that during this high estrogen phase that estrogen can increase nicotine metabolism because it induces the main enzyme, liver enzyme responsible for nicotine metabolism, cytochrome P450-2A6 or CYP2A6. So in contrast, the effects of progesterone, the other ovarian hormone, is low during this follicular phase when estrogen is high, but then increases during the luteal phase and is higher than estrogen during the mid-luteal phase. And so the specific effects of progesterone are that, in animal studies, it correlates highly with a decrease in the desire for nicotine or nicotine self-administration. And there's a decreased urge to smoke when people are administered exogenous progesterone. And there's actually, during this phase, a decrease in Curie activity and symptoms of negative affect, which is the opposite to what has been reported during the high estrogen late follicular phase. And also during the luteal phase, there seems to be better performance across measures of cognitive control and sustained attention. And this sort of cognitive control has been related to the ability to resist a cigarette and to prevent relapse. So when both estrogen and progesterone are high during pregnancy, for example, you can see an increase in the CYP2A6 activity, which leads to an increased nicotine metabolism, which can increase withdrawal symptoms and lead to the more difficulty in quitting that pregnant women often report. Some contraceptives, some hormonal birth control that have higher levels of estrogen also increase nicotine metabolism, leading to increased withdrawal and cravings. So, there's a lot of evidence that these ovarian hormones do influence people's either subjective experience with nicotine-related withdrawal and craving symptoms, as well as changes in metabolism of nicotine. So, however, not very much is known about menopause. You would think, or at least I think, you know, if these hormonal fluctuations are so closely related to differences in nicotine withdrawal and craving, once during menopause, when these levels don't fluctuate anymore, they're just kind of at a low steady state level, that this is maybe the time when women would be more likely to perhaps be able to quit smoking. So when we looked at this in the STOP data, again, you know, the previous analysis we did was just looking at differences between men and women. And this analysis is looking at differences between men and women, but across the lifespan. So we just kind of binned everyone in 10-year age groups. And you can see overall that regardless of age, men are more likely to quit smoking in the STOP program compared to women. When we tried to estimate the kind of time of menopause, or, you know, trying to separate women between premenopausal and postmenopausal, so we kind of did a cutoff at age 50, thinking that perhaps the slope would change, and it did change. You know, at the age of 50, the slope increases and people are more likely to successfully quit smoking from age 50 onward in a nice linear fashion that you can see there's no difference between men and women in this ability to increase smoking cessation rates after the age of 50. So again, no strong evidence, but this is a very arbitrary cutoff. We know that menopause can happen anytime between late 30s, early 40s to late 50s. So, you know, this is a very kind of crude predictive model that wasn't very successful. So we need to go back to the drawing board with that one. But when you look at the existing literature, published literature on the effects of ovarian hormone, menstrual cycle phase, and treatment outcomes, there is evidence that with respect to treatment with nicotine replacement therapy and counseling, that if people quit during the follicular phase, it might lead to better outcomes. But again, the results are a little bit mixed. And then there's also some evidence that quitting during the luteal phase might lead to better outcomes. So again, contradicting evidence. We don't really know which phase is potentially better. So with that, we decided to conduct our own randomized control trial that Pina is going to present on. This is her PhD work. And really the rationale is the fact that, you know, within the literature, there are these inconsistent findings, and, you know, the limitations that we could find with the published studies is that, you know, that the actual timing and the confirmation of which phase women are in when they quit smoking was not perhaps as well done as it could have been. And we also know, you know, that providing women with NRT and behavioral support will be effective, but we can potentially make it more effective by timing their quit date to two different phases. So I think I'm going to turn it over to Tina now.
Okay, hello everyone. Not sure if I can change the slides yet.
Yeah, you'll be able to change the slide.
Okay, thank you so much, Rachel. Okay, so thank you so much, Laurie. I will now give you a brief overview of my research on menstrual cycle and nicotine replacement therapy, which is otherwise known as MCRT. So we have already talked about how menstrual cycle and ovarian hormones can play a role in the success of smoking cessation. So hence the timing of aided smoking cessation to a menstrual cycle phase could be an accessible and cost-effective way to mediate the observed sex gap in cessation outcomes. However, as of right now, and as Laurie mentioned, there are no conclusive findings on exactly how ovarian hormones play a role in smoking cessation, or which menstrual cycle phase is better to initiate treatment. So timing treatment to menstrual cycle phase is a relatively recent area in smoking cessation, and researchers have previously used NRT, behavioral support, and medications. However, we are primarily interested in the combination of NRT and behavioral support, as it has been described as one of the most effective approaches to smoking cessation. Findings on which phase leads to better outcomes with NRT and behavioral support are not consistent. Some of the findings were non-significant and many were limited by the sample size and the lack of consistency in choosing a point within the menstrual cycle phase to initiate treatment. As such, some researchers targeted mid-follicular and mid-luteal phase, and others targeted late follicular and late luteal phase. There are also no consistent findings on the benefits of any particular menstrual cycle phase over usual care. Therefore, the goal for our randomized controlled trial is to find out if there are any benefits of targeting the initiation of NRT to either follicular or luteal phase. We are aiming for the sample large enough to lead to some conclusive findings. And if these findings are significant, targeting NRT and behavioral support to a menstrual cycle phase could be potentially added to smoking cessation guidelines in healthcare. It is an intervention that can be implemented relatively easily, and combined with the accessibility of NRT, this approach could improve cessation outcome in people with menstrual cycles. So MCNRT is fully virtual, and overall we're aiming for a sample of 1,200 participants. We mail a 6-week supply of NRT, which includes nicotine patches and nicotine gum or lozenge. Our participants receive nicotine patches of different dosages depending on how many cigarettes per day they currently smoke. They are also advised to move on to lower dosages at weeks 5 and 6. We also provide access to a behavioral support app, although the use of behavioral support is optional for this study. Participants will also complete daily and weekly surveys online to assess their NRT use, smoking abstinence, mood, nicotine withdrawal symptoms in the 6-week period of their NRT use. To be eligible for MCNRT, individuals must be aged 18 to 40. They must be naturally and regularly cycling, which we define a regular cycle as anything between 21 and 35 days for the past 6 months. They must not have taken any hormone-containing medications in the past 6 months. They must not have any unstable psychiatric conditions. They must not be currently taking any smoking cessation medications and NRT, and they must be currently residing in Ontario. Okay, after individuals complete informed consent and screening online, they are randomized to either mid-follicular, mid-luteal, or the usual care group. The mid-follicular group initiates NRT 6 to 8 days after the onset of menses, and the mid-luteal group 6 to 8 days before the anticipated onset of menses. These dates are calculated based on the menstrual cycle information that the participants share with us at the beginning of their study. Those assigned to the usual care group will initiate NRT within 30 days of enrollment, regardless of menstrual cycle phase. Day 1 is the day of NRT initiation. On that day, participants will be asked to abstain from smoking moving forward, and also we ask them to provide a blood spot sample or DBS and mail it back to us using a prepaid label. We will use those samples to measure ovarian hormones and confirm menstrual cycle phase, as well as the levels of nicotine in their blood. On day 7, participants are asked to report their smoking status. If they have not smoked since day 1, they are asked to provide a second DBS. On week 6, which is the final week of NRT use, we again ask to report smoking abstinence. If a person has been abstinent for the previous 7 or more days, they will be requested to submit another DBS. And at the 6-month follow-up, this procedure is repeated again. So our primary outcome is the 7-day point prevalence of abstinence on day 7, which we will compare between groups. This is our short-term outcome. The secondary or the long-term outcome outcomes, I should say, are 7-day point prevalence of abstinence at week 6 and 6 months. These will also be compared between groups, and we will test for any correlations between short-term and long-term outcomes. We will also carry some analyses of mood, depressive symptoms, nicotine withdrawal symptoms to investigate how they differ between groups and time points. So we launched the recruitment in December of last year, and we anticipated to complete recruitment by the end of next year, but we might have to revise this timeline in the future as we establish our recruitment rate. So as we only launched recruitment a few months ago, we're still working on getting the word out about MCRT and establishing the regular flow of participants. And this is why I'm really happy to share the information with all of you. I think that MCRT could serve as a helpful cessation tool to many people, and it doesn't matter which group someone is randomized to, they will receive free NRT and access to behavioral support, which increases their chances of smoking cessation. So if you know someone who could benefit from this, please direct them to our website, which is listed here on the slide. The website has all information about MCRT. If someone is interested in signing up, all they have to do is follow the link on the website, and it will redirect them to the informed consent. And I'm always there to answer any questions via email, which is also listed on the slide and on the website. And here's also a brief recap of people that we're looking for. Please feel free to take a picture of the slide if you'd like. And I think this information is also being shared in the chat. Thank you, Rachel. If you would like to receive some flyers about MCRT that you could maybe share with your patients in your office, please email me and I would be happy to send them your way. Thank you so much for listening, and now I will pass it off to Marium, who will talk more about her fascinating research on menstrual cycle and neural activity.
Good afternoon. Happy International Women's Day. Do I have control of the slideshow?
Yeah,
Okay.
yes, you do.
Okay, perfect. So as someone mentioned in the chat, up to this point, we have not mentioned a very common nicotine delivering device that is now used very widely, especially among the youth population, and those are electronic cigarettes. So e-cigarettes or vapes are handheld battery-powered devices that essentially produce an aerosol by heating a liquid that contains nicotine, which is the addictive compound that is present in both vapes as well as tobacco cigarettes, and they also deliver flavorings and other chemicals. So as these devices do simulate smoking, they were originally marketed as a smoking cessation tool to help smokers quit or at least reduce their smoking intake. And vapes are technically considered to be less harmful or toxic compared to traditional cigarettes, as they don't involve burning tobacco. However, recent studies are showing that e-cigarettes have ultrafine particles and volatile organic compounds that can also cause damage to the lungs. So similar to tobacco smoking, there is substantial evidence that e-cigarette use results in symptoms of dependence, leading to essentially a rising concern that there is going to be nicotine dependence among younger populations as well. So while Canadian tobacco rates have substantially decreased over the years, the use of electronic cigarettes is now widespread and on the rise, as you can kind of see from this slide. So as we know, nicotine is a highly addictive substance that is present in, like I said, vapes and cigarettes. And when nicotine is consumed, it actually stimulates the release of dopamine, which is a neurotransmitter. And this results in the feelings of reward and pleasure. And this is what makes nicotine so addictive. So these users will associate nicotine with pleasurable feelings, and then with the act of smoking and vaping, and then continue to use nicotine products to experience those same sensations. And this is exactly why it's important to study addictions from a neurological perspective, or through essentially the brain disease model of addiction. So getting back to menstrual cycles, there are some pilot studies that have investigated the effects of menstrual cycle phase on neural activity in smokers. However, similar to the treatment studies, literature is limited by small sample sizes. It's not very common for the hormones to be confirmed with biological measures, and no studies to date have investigated the effects of menstrual cycle phase on vaping. Okay. So accordingly, my research in Dr. Zawertailo's lab studies the effects of menstrual cycle phase on neural activity in exclusive vapors as well as exclusive smokers. And we have three main aims for this study, and it is to study the effects of menstrual cycle phase on 1, Curie activity, 2, resting state functional connectivity, and then 3, cognitive performance and craving. So the first aim of my study is to compare the effects of menstrual cycle phase on Curie activity. So studying Curie activity, Laurie kind of briefly went over this. It's essentially looking at brain activity in response to being presented with drug-related stimuli, such as showing smokers and vapors pictures of people smoking and vaping. And people associate these cues with specific moods or sensations, and environmental factors, basically with the rewarding effects of the drug. And when users view these cues, there's brain activity that is present as a bold signal, and bold stands for blood oxygen level dependent signal. So this actually gives us a direct biological indication of nicotine craving and dependence, and it's been used as a great biomarker for disease severity. And essentially, greater Curie activity in addiction-related regions of the brain during a certain phase of the menstrual cycle may actually indicate greater vulnerability to cues during that specific phase. So the second aim of my study is to look at the effects of menstrual cycle phase on resting state functional connectivity. So resting state functional connectivity, as the name implies, is looking at brain activity at rest or in the absence of a goal-directed task. So as opposed to Curie activity where we're showing them cues, during this scan, all we ask is for the participants to close their eyes and let their mind wander. And resting state is actually thought to represent inherent brain organization, which can influence brain function and behavior. And it can give us more trait-like characteristics to determine at rest. So essentially, without having anything to do to directly induce craving, what phase of the menstrual cycle may actually be more vulnerable to increased nicotine craving and the rewarding effects of the drug. And of course, this would be dependent on the brain regions that show increased or decreased functional connectivity. And resting state has actually also been used as a biomarker for nicotine dependence. So finally, the last aim for my study is to compare, basically study the effects of menstrual cycle phase on cognition. So in addition to neuroimaging, neurocognitive assessments have been used widely in research to better understand substance use disorder. And in fact, impaired cognition, such as impairment in learning, memory, attention, and impulsivity, has been recognized as a distinctive feature of addiction. So for example, a test that we may be very familiar with is the Stroop color word task. So this specific task measures impulsivity and attention. So this is just to give you a rough idea of what a specific neurocognitive task could be. And essentially, we will be studying how menstrual cycle phase may impair cognition between vapors and smokers, and then if it's different between the follicular and luteal phase. Okay, so briefly, my study is designed to have 3 visits. So an assessment visit will be the first visit, and it's basically just to obtain consent, baseline demographics, and of course, confirm eligibility. And then once participants pass that assessment visit, they can be booked in for their brain scanning visits. So the brain scanning visits, they're identical to each other. So one will be during the late follicular phase where estrogen is at its peak, and one will be during the mid-luteal phase where progesterone is at its peak. And we ask participants to refrain from nicotine. So if they're a smoker, refrain from smoking, and if they're a vapor, refrain from vaping for at least 12 hours prior to the visit. And we will be completing that Curie activity task, a 10-minute resting state functional connectivity task, and then 5 neurocognitive tasks that we have chosen. Overall, my project aims to investigate which phase of the menstrual cycle and in turn ovarian hormones make women more vulnerable to nicotine dependence from a neurobiological and neurocognitive perspective. So do you know any vapors or smokers who would be interested in completing the study? On the slide, you can see the basic eligibility criteria for the participants. If there's anyone in the Toronto area that would be interested in completing this, or you know anyone that would be, I would really appreciate it. So my email is at the bottom over there. My inclusion and exclusion criteria is very similar to Tina's. If they're exclusive vapors, they can't be past regular smokers. And if they're exclusive smokers, they can't be past regular vapors. Again, regular menstrual cycles, no use of hormonal modulation, so no birth control. And other than that, I'll send it back over to Laurie for concluding remarks. Thank you so much.
Great. So you can tell we're using this webinar to recruit participants, but that's okay. Because we have the audience that can potentially help us, and all of these studies, I think, will help us further our knowledge and of the role of hormones in smoking, vaping, addiction, and potentially treatment outcomes. So I think there's one slide. I have control again, Rachel.
Yes, you do. Yeah.
Great. So hopefully, we've established the learning objectives at the beginning, and hopefully we've obtained them. So now hoping that you've learned about and can recognize the known sex differences in nicotine and tobacco dependence, and that we've furthered your understanding of the role of ovarian hormones and menstrual cycle phase in addiction processes and in smoking treatment outcomes. And that you also have a better understanding of the limitations of the current literature, and have learned about our ongoing studies here at the Nicotine Dependence Service / Intrepid Lab at CAMH. So, just some final remarks. Women are disproportionately affected by nicotine and tobacco dependence. We do need to focus or provide a women-focused treatment in clinical practice. I'd love to hear your experiences with women trying to quit smoking in your practice, and if you do see specific differences. The research that is out there and published is limited by small sample sizes and either a lack of or poor biochemical verification of menstrual cycle phase. But there is still growing evidence that menstrual cycle phase and ovarian hormones do have a significant impact on nicotine addiction and in addiction processes in the brain. So yeah, we're now happy to take questions. I think we've left sufficient time. So I think I saw one or two in the chat already. So I think the one question was about whether penis study is open to vapors as well as smokers.
Yeah, so I think I've answered this in the chat already, but just
Okay.
as a recap, we're currently not taking any exclusive vapors, but like dual users might be suitable for this study.
Yeah, so we do accept some vapors as long, but they do have to also be smoking. So dual users. And I think we've answered the question about whether vaping has a similar impact on women's hormones. It's not currently known at all. I think there's just so little known about vaping that any research question you might have about it probably hasn't been answered. So we're trying to rectify that.
Does anyone else have any more questions? Okay, well, I will, as you can see on the slides, you can see everyone's email information. So feel free to reach out if you do have any questions at any point. I do want to say thank you to our presenters. I can tell from the chat and the reactions that everyone found it as engaging as I did. So thank you very much. I just want to remind people that the webinar has been recorded, and I will be distributing a link to that as well as a copy of all the slides to you all by tomorrow afternoon. Please feel free to share with your colleagues. I will also be sending a link to the evaluation and post-learning assessment that should be completed by next Wednesday, March 15th, in order to receive your letter of completion. And I'll also just include our information for our next webinar coming April, and it's on anxiety and smoking, cannabis, and vaping use. And if you want to view this webinar again, or you've missed part of it, or you want to see another webinar we have, all of that can be found on our website as well. I did notice Jenna had a question.
Yeah, so do we have any research on the most appropriate way to bring up gender-based behavior change to patients? That's an excellent question. I mean, I think, you know, TEACH has women-specific training for, you know, tobacco dependence across the lifespan for women. I think you know, I think you have the relationship with your patient, and you probably know the best way. I don't think there's one best way to broach the subject. And I think, you know, just acknowledging that there's specific challenges that women have compared to men when it comes to quitting smoking, and perhaps, you know, getting the women themselves to recognize what those might be. You know, it's not the same for everybody, but just bringing it up in a general way might be the best. But I'm not a clinician, so I unfortunately can't really answer your question. I'm sorry. But we can bring it to the TEACH listserv, and perhaps our team here can give you more information, Jenna.
I think Carol had a question too. Any research regarding persons undergoing hormone therapy for sex change and nicotine addiction?
Right. So, not that I'm, sorry, aware of. But we know that smoking, tobacco dependence, vaping is highly prevalent in those groups. I'm not aware of any specific research regarding them, but it's a fascinating concept. I don't know, Tina or Marium, if you come across anything in your readings.
Very little on ovarian hormones. I'm so sorry, I have to cut you off.
Yeah.
There's very little on ovarian hormones, and especially hormone therapy. I think there was 2, maybe 3 papers on birth control, and that's kind of the only hormone modulating therapy and nicotine kind of association papers that we found. Not any specifically for sex change that I've come across.
Mm-hmm.
Yeah, that's basically what I was going to say too. So yeah, not really a lot of research in that field yet, unfortunately.
Great. And then, sorry, Laurie, you did mention the listserv, so I'll also just post the email in the chat. If anyone is interested in joining, feel free to just send an email and then put subscribe in the subject, and that's how you can join.
Oh, great. Thank you, Rachel.
And I think Megan has included a link to how to find information on the Expand project. If anyone is interested, you can look in the chat for that. But if there are no more questions, thank you everyone for listening and participating, and I hope you all enjoy the rest of your day. Thank you.
Thanks, everyone. Bye.